Welcome back to Lesson 2. In the previous part, Part 1, we talked about palliative care philosophy. Now in this second part we will introduce some self-care strategies for healthcare professionals, which face loss and grief experiences. In this lesson, you will learn aspects that affect the experience of loss and grief for healthcare professionals, the context and ethics that surround such experiences. We will discuss also what self-care means, and why it is important for healthcare workers, and what are the strategies that can be implemented to maintain a good physical, psychological and spiritual balance in your personal life, and in the workplace. We will first address the issue of bereavement and loss, and how these experiences affect the health professions in a very particular way. Where there is a bond, if it is lost, there will be grief. A therapeutic bond requires the emotional involvement necessary for the cure, and if the bond is dissolved, emotions of anger and sadness, typical of grief, can be experienced emotionally. The group can represent an elective place for the sharing of experiences, and the space-time container useful for the grief of the practitioner. Francesca, a doctor working in a psychiatric service. I know it can happen, but as far as I'm concerned, I can't get used to it. The habit of some of my colleagues to this kind of thing seems to me a form of self-protective cynicism that reduces the work to little more than mere execution. They do it so as not to get involved, but not to get involved for me is to let their work cool down, becoming something aseptic. If you are dealing with people, this is not possible, if you have to make an effort and consider this a waste of energy. You may not notice results on the surface, but under the ashes. 3 months ago a patient committed suicide. The therapy was always difficult with him, but he came to the appointments, he seemed to make some progress. Occasionally a few relapses, then a recovery. There was a bond, a working alliance, however fragile. Without saying anything, without any warning. I felt bad for him, but I felt bad for me, too. At first he made me angry, then I felt strangely down, without thinking directly about him. A family member of mine pointed it out to me. They said I had a weird face. I talked to a psychologist friend and she told me about grief. I thought it wasn't about that. I always thought grief was for a close relative. Thinking about it and describing how I felt, she confirmed that I was in mourning, a traumatic mourning for the way things had gone. All those involved in the helping relationship derive strength, satisfaction and motivation from their work, when they feel they are doing it well, when they manage to keep alive the passion that has led them to care for other human beings in difficulty. The passion is also nourished by good results, successes, acknowledgements and gratifications that arise in the relationship, with the people they care for, and even with their colleagues. The results do not depend essentially on the mere statistical count of performance, the economic plan alone, the efficiency and effectiveness of the service, let alone the power games. Every operator of the helping relationship, whatever the context in which he or she works, his or her position and function, must also face the limit, the worsening, the loss, the mourning. Operators are also challenged with grief. When an operator goes through mourning as part of his work. Whenever he has the experience of the limit and loss. Going through mourning requires some preconditions, moving from grief care to memories care. Each operator of the helping relationship moves along 3 main axes for his actions. 1. The promotion of health. 2. Prevention. 3. The cure. All 3 of these areas of action are aimed at the individual, families and communities. Care gathers all those actions, in which it is necessary, to support and accompany people in critical moments related to chronic diseases, permanent discomfort or restrictions, end of life, mourning. The treatment can be temporary or permanent. In order to have a meaningful supportive relationship, specific skills, related to the scope of action, and good emotional involvement are needed. There is a similar relationship between professional competence and emotional involvement, as there is between rigor and imagination, static quality and dynamic quality. Without a dynamic and harmonious relationship between these dimensions, there is a risk of paralysis or madness. In the best hypothesis, we live as zombies, living dead, because we let the spark, that should feed the small light that warms and orients us, go out. We go on with ethics and context. We will see how some factors, that we often do not consider, such as the pragmatics of communication, influence ethical aspects, and are redefined in different contexts, including the workplace. As part of the helping relationship, we must move from an ethics of beliefs or principles, to an ethics of consequences or responsibility. It is therefore important to take into account the effects of communication actions, the pragmatics of communication, that influence the functioning of systems, which can affect health. It often happens that many professionals, while working together, are not clear what is the epistemology of the healthcare service, the organization hierarchy and chart, the operational mechanisms and social processes. Having a shared idea of the context in which one is working, is also an important container for emotions. In this regard, it is necessary to consider a certain discrepancy that there may be between personal vision and group perception. We can have individual symptoms, organic, psychological, relational, due to diseases of the work team, which is called ecological burnout. Over the span of their career, healthcare professionals experience changes to their professional role and professional identity. The process of continual adaptation in their work setting incurs losses. These losses can be ambiguous, cumulative, and may require grieving. Grief in the workplace is unsanctioned, and may contribute to physicians' and nurses' experience of burnout, emotional exhaustion, depersonalization, low sense of achievement. Acknowledging loss, validating grief, and being prescient in dealing with healthcare professionals' burnout is essential. An important role in everyone's life is played by fear, and this also applies to work. We have to consider our own fear, the fear of the patient, and the fear of the relatives. We should ask ourselves, fear of whom and of what? Fears that make the practitioner afraid need to be treated. The fears mentioned in this slide require going through a mourning process. First of all, grief dictated by the experience of powerlessness. How then do we deal with the experiences of bereavement of ourselves, or of people we care for or who are close to them? The process can be divided into 3 stages. 1. Exploration. Exploration consists of historical narrative recall work that makes us better understand the emotional learning process. 2. Alphabetization, giving voice to emotions, knowing how to communicate them verbally and non-verbally. 3. Normalization, emotional sharing reduces the negative effects of emotionally loaded parts. It makes the emotion normal to the extent that, by sharing it, it reduces pluralistic unawareness. Pluralistic unawareness, for example, the idea that it is only I who feel certain emotions, ignoring that there are others who have lived similar experiences, is reduced through the normalization of emotions when they are shared, so the elective place for this type of experience is the group. In the group, one can develop self-reflexive capacity, trying to understand what premises we have for help, and what we should develop. An important role in everyone's life is played by fear, and this also applies to work. We have to consider our fear, that of the patient, and that of family members. It is noted that high personal spirituality and competence in spiritual care is associated with reduced burnout in palliative care professionals. While self-reflection on spiritual issues in the individual's own life should be a standard part of spiritual care training, it is to be noted that spiritual care is a new concept in many places, and that healthcare professionals have not been in the habit of practicing personal spiritual reflection as a professional requirement. Self-awareness can help the healthcare practitioner to avoid being distracted by their own fears, prejudices and restraints, and attend to the patient. There are practical challenges in facilitating an intimate process, such as self-reflection in a group of healthcare professionals. Solutions for different healthcare organizations include the following. The development of regular voluntary and formal forums, where staff can discuss personal spirituality over a cup of coffee, is supportive of self-reflection. Schwartz Rounds are an evidence-based forum for staff from all backgrounds to come together, to talk about the emotional and social challenges of caring for patients. The aim is to offer staff a safe environment, in which to share their stories, and offer support to one another. A Balint group is a group of clinicians, who meet regularly to present clinical cases, in order to improve, and to better understand the clinician-patient relationship, and to provide mutual support. Circle of Trust involves group study sessions, which focus on creating a space for staff members, to listen to themselves and reflect on their spiritual care practices. Continuing professional development opportunities to address personal spiritual development, such as spiritual retreats. An understanding of the human condition is considered to be a valuable contribution to effective spiritual discussion at the EOL, for example through engagement with the humanities, for example poetry, novels, art, etc. Caring for people with life-threatening conditions can have a profound effect on healthcare professionals. Without the ability to manage one's grief in response to the death of a patient, healthcare professionals may experience physical, emotional, cognitive, behavior, or spiritual distress, which could have implications for their professional practice. Keane and colleagues have developed some guidance on how to deal with bereavement in the health professions, including through group activities, involving all those involved in the care of the deceased patient. A bereavement debriefing session usually starts with welcome and introductions, in which the purpose of bereavement debriefing sessions will be reviewed. Then participants are invited to introduce themselves by giving their name, and asked how they have been involved in patient care. The next session discuss about factual information and death circumstances are being reviewed. A case review is then performed by proposing questions like, what was it like taking care of this patient? What was the most distressing aspect of the case? What was the most satisfying aspect of the case? An analysis of grief response is then discussed by eliciting participant to share their experiences, physical, emotional, behavioral, cognitive, or spiritual responses, after patient's death. A specific focus on the emotion also addressed in a specific session. Bereavement debriefing sessions will also discuss strategies for coping with grief, by reviewing the current coping strategies of participant, and assessing the available resources. Conclusion sessions focus on the lesson learned from this care and grief experience and, finally, acknowledgement of the care provided, and a summary of the available support for participants and patient's family. Now we will deal with the aspects of self-care, giving a definition, and finally suggesting some strategies to maintain a good level of personal reflection, and psychophysical and spiritual well-being for the helping professions. Self-care is an important part of everyday life for us all. We each take care of ourselves, as best we can in our daily activities, to maintain personal health and happiness, whilst also functioning at an optimal level in our professional endeavors. But self-care is more than you think, and it becomes even more important when we are faced with personal challenges or occupational stress. For people involved with palliative care, emotional distress, compassion fatigue and burnout are important considerations. Healthcare professionals are often termed heroes, means high expectation and risk occupation. The profession broadly, and the organizations that employ them, must be well aware of the needs of heroes. Hussain and Clatti, 2021, report that among self-care strategies of heroes during the pandemic, the optimal prognostic factors affecting professionals' experience were self-stewardship and moral resilience. Self-stewardship is the skill of tending to and nurturing one's well-being. Without self-stewardship it becomes challenging to stay healthy, and to serve others well. Self-stewardship, in particular, allowing oneself to be seen, helps nurses to contextualize the ethical dilemmas they face between patient-centered care and public health ethics. This helps an individual understand and appreciate that she does nothing wrong by providing public health-guided care. One way to self-care is by building moral resilience. Self-efficacy and self-control help nurses respond positively to distress they encounter as nurses. Moral resilience is the courage and confidence to confront distressful and uncertain situations by following and trusting values and beliefs. Being morally resilient allows one to maintain perspective, keep a situation in context, and understand that some conditions are out of one's control. From that position, the nurses can proceed without seeing themselves as deficient, not doing enough, weak, or neglecting others. Healthcare professionals often suffer from a form of cognitive hypertrophy that does not allow them to capture these emotional aspects that are important for health. Having free access to emotions means being able to share them, knowing that emotional involvement is essential for the helping relationship. To have a good emotional involvement means to have a good emotional governance. Emotions do not overwhelm, rather they allow to know better how a relationship is going. During the work of emotional inclusion, one should ask oneself, when and from whom did I learn about emotions, including the way of expressing them? It is about exploring, alphabetizing and normalizing emotions.